So in the last 15 minutes, I think we can open it up for discussion, but just to kind of put this in sort of the Reader's Digest version, I think, the three speakers nicely encapsulated what we have. We have reviews that show where the evidence is and where the gaps are. We have, based on systematic reviews, metrics that we can utilize. We have, from a realistic perspective, a framework that we can utilize these metrics in. So I guess open for discussion, the question is, what are the barriers to making something that seems so simple and straightforward to actually happening and creating, in a sense, the evidence in the body of research that everybody else is looking for, when to some extent, we're providing that? And why doesn't the policymakers, why doesn't CMS look at all of this and say, hey, here we go?
That we'd be crunching a lot of data. But the reality is that a lot of our clinical programs are focused on data primarily for ROI to the C-suite. So we have huge amounts of data that nobody is even looking at and could be contributing to the evidence base. And I'm wondering if there is some way we can even capture for the research world, like, this data exists, we just need an analyst to crunch it. And we know it's good data because we've done enough crunching to show ROI to the C-suite, but it's not for the purpose of publishing in a peer-reviewed journal. So that's number one barrier. And then number two is, all these kind of big reviews are great, but I think the piece that we're missing is, you have this compilation of studies that show effect and then a compilation of studies that don't show effect, but we're not looking at what are the common factors, for example, remote patient monitoring. For all those ones that have really good effect, are there some common factors across those programs that make them, really effective, as opposed to the ones who are not showing effective? We're not seeing a lot of that come out of it, and I think if we can do some meta-analysis that really looks more at common core pieces of successful programs, that might be contributing then to what Steve is talking about. How does this affect my practice?
Just my reaction to that, to sort of the global points that you just made, is, it gets down to what we were talking about before, which is sharing data. I mean, there's institutions that have grad students that are looking for projects. I mean, that's a dissertation right there, 2 or 3 dissertations. So could we, create a network among ourselves where we say, okay, I have X data set, here's the topic of your dissertation, I'm willing to share, anonymized or, however, do we have any volunteers? I mean, that's potentially one thing that search could provide.
We have another comment.
So I was going to actually make 3 related points to that. And I was going to actually ask Steve, because Steve has figured out, one of the vendors he used stunk, or he couldn't get connected, and then they replaced it with a vendor that had a 1.6% failure rate. Comes back to my comment yesterday, every one of our contracts should allow us to publish our experience. There's no reason I should ever sign a contract with the crappy vendor without knowing that they failed to perform in some other site. Right. But right now we can't publish that. So we have to set ourselves up to be entirely transparent so that I don't make the same mistake you made. I would have no way of knowing that, so we are doing better for our patients and fitting into the right things. The second thing, I'm going to challenge one of Kathy's assumptions, and if one of my ER colleagues could go stand next to Brendan when I say this, you might need to resuscitate him, and we could do it in person. I think we need to, in advancing telemedicine, we have to some degree in the short term, I don't want to say ignore the peer review literature, but not rely on it. Because the time frame from which we generate new knowledge to it gets published in the peer review literature handicaps us in taking care of patients. So I think it's a little bit of an issue, and there's a whole bunch of these, what is referred to in my shop as like a journal zine, where you could write anything, somebody reads it over and makes sure you're not crazy, but it's not formal peer review. and it's published 2 or 3 months later, and people could find it if they know where to look for it. And we might want to have a strategy to share the information and just get it published somewhere. And then I have a challenge to HRSA and maybe to Marcia, in that I think what Kathy asked for is really brilliant. And so can HRSA, rather than funding different grants, think about maybe funding a data analytics center that could actually take the data from other sites. And to me, that would be brilliant, because it's one of the things that we had issues with as we discussed research. And we all know we all have the data, but we lack the resources, power, and in some places the intellect to actually analyze it appropriately. So I just throw that out for people to think about. It would really solve a problem if we could analyze data and get it out there really fast.
Yeah, so I just wanted to say, so first of all, that idea of like looking at studies that have positive effects and negative effects in our new systematic review, that's exactly what we want to do. So we are trying to do that. But a lot of the primary literature has a lot of these elements either poorly described or not described at all. So there's a limit. And a lot of what I do at ARC actually is working with real world data. I mean, I don't work with it. I try to help other people work with it. And we have, I don't know if anyone's seen, we have a handbook on registries for evaluating patient outcomes. And I work a lot with registries groups. And, you know, and I'm wondering if there's a way to set up a registry that has all the wonderful data that all of you have. And you know, one of the ways I work with the National Quality Registries Network, and you know, you all might want to interact with them. And with the new MIPS and MACRA rules, where people have to report quality measures, if there's a way of leveraging that as a way for you all to set up a registry and have people participate in it, I mean, I think that would be wonderful. And I mean, any help I could provide, I would love to.
I think one of the big, so at CTEL, we're a research institute, but we focus on the policies, laws, and regulations impacting telemedicine adoption. And one of the things that we are seeing from policymakers and what's driving them crazy is there's really no standardization of telemedicine. So telemedicine to them is really a continuum, and that's the truth. You have really great models that are equivalent to what you would do in person, and in some ways even better than that. And then you have other models that are scary, to say the least. And to policymakers, they can't really, it's hard for them to understand what is telemedicine because there's no standardization in our industry right now. And so that is making them take a really reactive approach. And I think that might potentially be impacting adoption at a national level, because there is some reactive policy by medical boards and state legislatures that, you know, we don't want this in our states impacting our patients because they have maybe a misinformed view of what telemedicine actually is because they've only seen one vendor. The other piece is in terms of future sustainability of telemedicine, in terms of corporate adoption, we're dealing with relatively low utilization rates of telemedicine. Adoption rate by large employers is only about 3%. They cite the same grievances. They're saying, you know, one employer has one type of telemedicine model and their employees love it, and a different telemedicine vendor will supply, you know, one of our other companies with a different telemedicine model. And so I think patients overall are they have lack of consumer confidence because they're not really sure what they're getting when they sign up for telemedicine. I think as an industry, we have to do a better job at branding and creating a standard way of providing care through this technology.
I guess my counterpoint to that would be policymakers have this underlying assumption that healthcare in general is standardized, but it's not. So why is telehealth being held to a higher standard? I mean, if I go into something as simple as blood pressure, I could have my arm down here, my arm up here, my arm here. It changes my blood pressure. There's no standardization for something as simple as that. In radiology, I just did this huge study on indications for headache. People come into the ED for headache. There are recommendations about what should be imaged, what should not, yet there's absolutely no standardization as to what people do within our own hospital system, let alone from institution to institution. So why are we imposing standardization on something that doesn't have standardization in the first place. And I agree to some extent there has to be, and there's recommendations across healthcare. But why is telehealth being held to a higher standard than anything else?
Well, I think the
Or what
real
do you mean by standardization?
Well,
then?
what I think the real problem is that we're not asking for a separate standard for telemedicine. The problem is that if the standard for treating a certain medical condition is doing a urine analysis, and I'm not a clinician, but we have telemedicine companies calling us, and they are diagnosing STDs for a first-time patient that they have never talked to and they have never seen over a text message, and they are prescribing them an antibiotic.
That is true, but we have standards within, a lot of our standards of practice, and all you have to do is refer them to some extent to those, society-established practices. So it's not that we have to invent new standards for telemedicine. We just have to tell them that, look, telemedicine is a tool and you're doing it different, but you still have to adhere to the same standards that we do in our traditional medical practice. We don't have to invent new standards.
I agree with you there.
Okay.
I just think that there's a general, there are some problems with branding and what is acceptable. There are companies that have specifically hijacked the name telemedicine.
Yeah, no, that's true.
And that is actually what is impacting policy, and that's why we're seeing really reactive policy. So when I say standardization, I think our industry has to say this is not acceptable, and we will not accept this type of vendor to claim that they are a telemedicine provider.
So if I could just also react to that, so a lot of what you were saying is why looking at randomized controlled trials isn't getting us the evidence to where we need to go, and why also a lot of the work I'm doing in registries, and one model that we're trying to encourage is to have this registry infrastructure and then have people do trials within that registry infrastructure, and that creates a standardization both of outcome measures. I would really encourage you to consider that, and we don't have a lot of time to talk about it now, but I'd be happy to talk to people more about it later and show you some examples in other fields of how people are doing that. And I also want to say, though, about the organization. So another level of standardization is not only about these new devices, but is telehealth being added on top of something else, or is it replacing something else? So, we're trying to get at that through the modeling project I told you about, and anything that you can send us, about how telehealth is organized in your systems would be really helpful.
I think it's also helpful sometimes to remember to remind policymakers, industry, and ourselves that there are no government regulations on the practice of medicine. The only one that exists is the MQSA, the Mammography Quality Standards Act, and that is the only federal guidance or regulation on the practice of medicine. I think that's important to remember, that it is not their job to guide the practice of what is done. Okay, are there one more comment, Bill? And that'll be kind of our last discussion point, and then we'll.
I just wanted to pick up real quickly. I noticed Judd said, HRSA should, and I want to pick up real quickly on actually, he's absolutely on point on that. And one of the things I have looked at, SAMHSA has a very good evidence-based data collection instrument that I actually looked at and said, is this something that OAT or Office of Rural Health Policy should do? We have the Rural Health Research Gateway, which I don't know if any of you have used. It's not focused on tele, it's focused on rural through our office. We also have the HRSA Data Center, which is an incredible repository of information. I was on it recently, and I'm pulling down Medicare stuff. I thought I was at Medicare, except it turns out I'm getting all this through HRSA. I called them and said, this is incredible. How do you guys do all this stuff? And they said, well, we're encouraged to serve as a repository to provide certain types of information for the entire public from other agencies like CMS, because we're pretty good at packaging it in ways that consumers can use it. They don't have anything that you can trace telehealth there. So I would love to do that. I think our office would support that. We just frankly don't have the manpower or the ability to try to pull these things together. So I'm very interested in specific comments as you are using HRSA tools, SAMHSA's tool, or others, if you have specific suggestions of things we should look at, we should think about, I'd love to take those back and see if we can get some energy to have a repository that we could support.